All right. Good morning, everybody who's on. We can't see you, Ben and I, but I assume some people are on and I assume some people are trickling in. And so we'll give it another 2 to 3 minutes before getting started.
Sounds good.
Michael, are you able to see how many people are in the room?
Yes, sir. We're at 19 right now, and it's going up and up.
Okay,
Can you
great.
see who's in there? Like specific?
Okay, so let's give it till about 11:01 and then we can get going.
That cause controversy? Jesus.
And just as a housekeeping item, if the attendees who are in could please just put in the chat who you are and where you're watching from, that would, I think, help this be a little bit more engaging, so that we kind of know who's there. Because as far as Ben and I can tell, it's just the two of us. That would be
Yeah, we're speaking into a dark abyss right now.
All right. Why don't we get started?
Sounds good.
Okay. Just let me get settled here.
It's right there. It's the ground. More. Yeah.
All right, Ben, you good to go?
I'm ready. Yep.
All right. Good morning, everybody. My name is Jamie Blaustein. I'm the CEO of the Sylvia Brafman Mental Health Center, joined by Ben Brafman, the Chief Clinical Officer of Sylvia Brafman. It's really great to be hosting the first Sylvia Brafman Mental Health Center Roundtable event. Ben and I are co-founders of the Sylvia Brafman Mental Health Center. Ben, at some point, maybe you can just tell, about your mom and why we named it after her. We'll get there in a minute. But yeah, really looking forward to an engaging discussion today. And the point of this series overall today, of which today is the first, is to engage on topical and pertinent clinical matters that are applicable really to therapists and treatment centers alike. And so today we are talking about good treatment. What is it? What are components of it? And essentially, Ben is going to be giving a guide to good treatment and specifically honing in on about 5 or 6 key components that are not all encompassing.
And Jamie, if I could just add this, that the term good, it's a loose, loosely fitting. We're talking about ethics. We're talking about doing no harm. When someone thinks of treatment, the things that we're going to talk about today, these are the things that I want people to be aware of.
Great. Just a housekeeping item to start. You may have seen an email that there was a Zoom glitch, a tech glitch of some kind, which essentially erased some of the information that you may have put in when you registered for this event. We want to make sure that we can promptly get everybody the certificate of completion for the CEU credits. So I believe Michael on our end had sent a follow-up email just letting you guys know about that and asking you to once more put in the information. Thank you, Lindsay. First one. Appreciate that. If everybody once again, because I know people are trickling in late, could just throw in the chat where they're calling from and who they are, that would be amazing. In any case, So an email went out just asking you to put that information in once more. Many of you have done that, I believe 60 or so. So if you have done it, nothing to do at this point. After the call, we'll send an additional email asking you to fill out your information once more so that we can ensure that we get you guys the completion certificate for the CEU credits. Today's session is going to be roughly 45 minutes to an hour of a presentation. Ben will be doing 90% of the talking. I will be the host. And then we'll follow that with roughly 30 minutes of Q&A. Please note that you are welcome to put your questions in throughout the presentation. We will get to it at the end, but as you think of things, we definitely encourage you to just sort of throw the question in, and we'll look at it towards the end just to keep this moving. Agenda for today. And by the way, I hope this isn't distracting, but I'm going to share my screen at times and then not share it because I don't want a presentation that frankly isn't the focus of this to overshadow Ben speaking about some of these topics. So I may be in and out. Would definitely welcome your feedback as to whether that was distracting at the end of this, so that we know going forward. So in any case, today's discussion, we'll start with just an introduction about the Sylvia Brafman Mental Health Center and Ben specifically. That's not what this is about. This is really about the clinical meat and potatoes, but I think it's helpful to have some context. Then we'll talk about the critical components of good treatment. Again, a list that we're deciding to hone in on today that is not all encompassing. We want to tackle future components in later sessions, but we're going to talk about these 6 today. Informed consent, proper diagnosis, family involvement, having fun as a necessity, patient retention, and continuity of care. And like I said, we'll then open it up to Q&A. And by the way, this presentation, it's meant to supplement the content, and so we'll send it around afterwards. But again, I'm more and more interested in what Ben has to say live on a lot of these topics than the presentation itself. It's not earth-shattering information. It's probably stuff that a lot of you know, but it's meant to supplement what Ben is talking about. I just want to speak for 2 minutes or so on the Sylvia Brafman Mental Health Center so that you have, like I said, a little bit more context. So I see there's a lot of people from New Jersey on this call. I'm from New Jersey. And by the way, let me just say real quick that the Sylvia Brafman Mental Health Center, we are a primary mental health treatment center located just outside of Fort Lauderdale in Florida. We feel more like a residential level of care, largely due to our clinical backbone, which is led by Ben. We can handle some acute cases. We have a housing component, 36 beds. And the way that we came to be, it's really a story that's sort of like 14 or 25 years in the making, however you want to look at it. But I'm from New Jersey, a lot of New Jersey on this call, it seems. And I was a really good kid growing up, no major issues. In fact, super ambitious, class president every year of high school, prom king, all of these accolades. And I went to the University of Michigan for undergrad, and things got very bad very quickly for me. It pretty much kicked off a 7-year nightmare of rehabs and overdoses and arrests and psych ER visits and all of the insanity that I know people on this call are so familiar with. So I start going to rehabs, and my 4th rehab when I was 21 years old was a place in South Florida called Destination Hope. That's where I met Ben. Ben was the founder of Destination Hope in 2007. He actually kicked me out of treatment. I was a very bad boy, and I was not ready. I was not ready to do what I needed to get better. I finally did get it after 7 rehabs when I was 24. I just celebrated 10 years clean and sober. And I got really into mental wellness, really into recovery, and everything in my life transformed as a result of that in an amazing way. I got really involved in AA and 12-step work, but in other modalities outside of that as well, spiritual, clinical, and all of these external blessings really just sort of fell into my lap as a result of the internal transformation. And that's why I'm so grateful for all the great work that everybody on this call does, because it starts with the inside. And so I had this internal shift in terms of how I viewed the world. And then, the universe or God or whatever you want to call it just started throwing these blessings my way, and the world started to cooperate. And so I eventually went to business school, got my MBA at Duke, went to Wall Street, did investment banking in New York City. And then about 3 years ago, Ben reached out and he said, "Hey, I sold Destination Hope and I want to do something that's primary mental health, a little bit smaller and more intimate. Do you have any interest in being involved?" I really had no plans on leaving New York or my job. I told my mom though about what I was thinking of doing, and she immediately said, "Don't do that. You are 30 minutes away from me in New York City. You've got this amazing job. Don't take that risk." And then I told her who it was potentially with, Ben, and she immediately forwarded emails from like 3 years after I'd gotten kicked out of Destination Hope, where Ben was checking in and wanted to see how I was doing. And that meant a lot to her because obviously it meant that his heart was in the right place. But beyond that, she remembered that clinically he was exceptional. And so I had mom's blessing. And I did this because it was just the perfect match in that it got Ben squarely back in the clinical lane. At Destination Hope, Ben was the owner, the CEO, the COO, the CCO. And he really wanted to get back in the clinical lane and be hands-on and in the trenches with the clinicians and the patients. And meanwhile, I like business and I have my own personal journey. My recovery is somewhat separate from that, but the spirit of it comes into business as well. And so I get to do the business and I get to do so with a patient advocate hat on, given my own experience, and Ben gets to run the show clinically. And so we're doing a lot of great work for patients and families. Yeah, Ben, maybe you can just share a little bit about yourself and your experience.
Sure. Thank you, Jamie. Good morning, everyone. Michael, thank you very much for doing this. I'm Ben Brafman. I'm the Chief Clinical Officer of the Sylvia Brafman Mental Health Center. I've been in the field of behavioral health for 26 years now. I started from the bottom as a nurse aide back in the early 90s. Many of you would know that as a behavioral health tech or mental health tech. And I worked in every facet of treatment that I possibly could. I knew I loved it and I wanted to be part of it and make it my career. So I worked in psych hospitals and inpatient and outpatient services, and worked as a case manager and discharge planner and therapist. I got my master's degree. I got a dual master's degree in counseling, mental health counseling, and family therapy. I was in private practice for a little while. I worked for profit, nonprofit. I also got my certification as addiction professional and teaching and doing all those things. And then it really led to 2007, where I opened up Destination Hope, which at the time, which was in South Florida, was an all-male, gender-specific treatment program. Totally unheard of, but I really wanted to follow the research that had indicated that gender-specific treatment works, and it works well. And I kept the numbers low, and indeed it did work. 3 years later, I added the women. Completely different experience, but nonetheless successful. I did a lot of things like that within that company, age specific, trauma specific, psychiatric specific. It built it up where it was became over 15 years, a detox res to outpatient. And as Jamie said, and he alluded to, I really got burned out, and I didn't want to do everything for everyone, and I really wanted to hone in on clinical services and operations. So reached out to Jamie about 3 years ago. We opened the Sylvia Brafman Mental Health Center, and we've been going at it since then, and been very successful helping patients and their families. Just a little note here: the program is named after my mother. She was an amazing person. She passed in 2009 from cancer. You know, it's great to see her name every day. It keeps me straight, that's for sure. And you know, I ask myself, you know, what would Sylvia do? And so we do the right thing. We do the next right thing. And we do it in the spirit, and I've told Jamie about her, but we do it in the spirit of my mother, which is high empathy, a lot of individual care, you know, really getting into the minutia of what works for a patient and their families. And everybody here is a name, not a number, and that's the way treatment should be. And I'm looking forward, Jamie, to the discussion today, or you know, the webinar and stuff. To the topics, they're really important. You know, good treatment, it needs to exist right now. Mental health right now is at the forefront. It's finally getting the exposure that it deserves. So is substance abuse. You know, it all is. Some of it's for the right reasons, some of the wrong reasons. But as change agents, as all of you are, you know, this kind of webinar, you know, with the instructions and education, the hope is that it's gonna help. It's gonna really help you as a professional, and then of course in return help people all over the country. So very excited, Jamie, to take this opportunity and run with it.
Great. Thank you, Ben.
You're welcome.
Before we jump into it, just want to say one more thing, that Ben and I are very hands-on, and we love connecting with therapists, with other folks in the industry. We connect actually with families directly. Almost every admit that comes in here, the whole family has a Zoom with Ben and I. So we would love to connect with everyone on here individually, learn about your practice. Please don't hesitate to reach out so we can set that up and be resources for one another after this Zoom. So again, I'm going to be sort of in and out of this deck. I don't want it to distract the core messaging. But Ben, you know, we talked about 6 things that you wanted to talk about specifically today. And the first one is informed consent. Can you just talk about what is it and why is it important?
Sure. So and in the formation of this, I know that, you had some questions about, well, why informed consent? What's the big deal about that? And what I want everybody to know is that,
well, yeah, Ben, just to clarify what he means by that, I asked him to define it because I'm not clinical.
Right.
And I was like, yeah, well, obviously, isn't that sort of just the underlying component of, any sort of healthcare or provider, dynamic? And so why is that one of the things that you want to talk about? And so.
Absolutely. And Jamie's good that way because he's not a behavioral health guy. And so we really chiseled down to the core, of what's, of what's needed. But informed consent basically is an integrity contract. What it is patient comes into treatment and they're signing a bunch of documents. They don't read the documents, they're just signing and going ahead. And of course, when there's a problem, they go back and they say, you didn't tell me this, you didn't tell me that. Informed consent is basically a treatment center telling the patient, listen, these are the treatment modalities that we are going to do with you. Here are the possible outcomes. Here are some of the consequences, both positive and negative. And this is why we do it. And so for example, let's just take a really common therapeutic intervention, cognitive behavioral therapy. So in cognitive behavioral therapy, we're going to challenge a patient's core belief system. We're going to challenge their experience within their family dynamic. And the consequence of that is positive and negative is they actually might change and might feel better about themselves and their family. The other side of it is they might have some pretty strong feelings about it. They might get actually more depressed or more anxious or more angry. So we want to be able to share those things. But the other thing that informed consent does, and I mentioned an integrity contract, is it says that, listen, we're going to do a job. We're professionals. This is the job that we're going to do. This is the expectations. You can expect me to meet with you individually. You can expect to be in group. You can expect to eat. You can expect to get your medication right, all that stuff. But the other side of it is, as a patient, this is the expectation. We expect you to participate in treatment. We expect you to be medication compliant. We expect you to allow us to speak to your family and help you, and all those things. And the reason that I say integrity, an integrity contract as informed consent, is that it becomes more important. Integrity is, no one is looking, and you're doing the next right thing. It's making things right. It's saying that you're an honest person. And right away, treatment has started. You're not even in any groups yet, and you're sitting there and you're filling out this paperwork. And if you view it from the point of, this is an integrity contract and this has value, the patient will consider it more. The families like that. And then as professionals, it's more important to get your point across so that you're clear, which of course, Jamie, speaks to the critical component of communication.
Do you
That makes
find that
sense.
do you find that this is particularly more important with either certain types of patients? I mean, obviously it's important for everybody. It's like there's a whole bunch of considerations, clinical, ethical, etc. But do
Yeah.
you feel like you need to maybe be a little bit more delicate or nuanced with it, with either a certain type of patient or a certain type of modality that you're going to
Yeah,
offer?
sure. No, for
Because like
sure.
EMDR is one, for instance, that I always think of when obviously there can be rough if it's not done at the right time. And again, I'm not clinical, but I know that there can be negative implications with EMDR. People should be aware of that possibility if they're not quite ready for it.
Right. And
Stuff
in
like
this
that.
day and age, no, you're right. EMDR is a great example where people need to know about trauma and the things that may come up during therapy. The other thing is related to what you just said is, there's things like TMS now, right? And brain scanning and all this other, outside the box kind of stuff that, that patients need to know about. But here's the critical thing, is that it forces the staff to know what the heck they're talking about. Because a lot of times in treatment, and I'm sure the people on this webinar can relate to it, they just kind of like repeat what's said, and they don't really know, what's TMS? Well, it's a thing that, they put magnets on your brain and it's good, but it's not important right now, It's like, no, you should know about it. The staff should actually know about it. What is EMDR? The staff should actually know about it enough to be able to explain it to somebody. So absolutely, it is nuanced. You want to be transparent. That's the other thing, is that, you don't want to come across as like, don't worry about it. We'll talk about it later. It's not a big deal. It's a check the box thing. No, want to take it seriously.
Yeah. No, I know that when I was in the shoes of a patient, a decade plus ago, establishing that level of trust and intimacy was super, super important. So I guess now thinking back, I understand why you have it in this presentation.
I do, and it's really, it's really right out of the gate. We spend a lot of time on customer service, and trying to get things right. This is something that, like, it calms everybody down. It just, like, just relax. Let's go through it. We're not gonna hurt you. We're not gonna do anything to, we're not sticking needles in your eye. We're not, nothing like that. So, so again, that's why I really wanted to make this point clear, right out of the gate.
Right. So the next item we have here, number 2 of 6, is proper diagnosis. You talk about this all the time because we get on the phone,
All the time.
we get on Zooms with families, and you actually don't really ask what the diagnosis has been, but typically, because you're actually more concerned with other elements, but it often comes up, and
Yeah.
I know you always harp on we have to get that right up front.
We have to. I'm afraid to ask. I'll be honest with you. On some of the Zooms, I don't want to know. Sometimes it, like, tarnishes the interview and the conversation. But here's the deal. The deal is that you've got to get the diagnosis right, or let me preface it by saying, right enough. And so what I mean by that is that, for example, people come into Sylvia Brafman. We're not a 30-day program. We're not a basic primary treatment center. We're extended care treatment center. We look for 90 days or more of treatment. And go from there. What you want to do is you want to actually read as much documentation as you can, from the referring hospital or referral source, and you want to interview the patient, and then if you can, you get collateral information from family members, and then you talk to staff. In our case, our psychiatrist and I, we spend a lot of time on the front end, and discussing it, whether it's emails or texts or in person. And so we make a judgment call. But it's flexible enough, and this is a critical piece. It's flexible enough to know that, 2 weeks down the road, a month down the road, honestly, more than that, we could change it. And here's the thing about this, Jamie, that I wanted to hit home today. I am very frustrated with the behavioral health industry and the laziness that goes on. I have read documentation. I actually read the documents. I've read these documents, and these people are diagnosed with schizophrenia. And I mean, schizophrenia is kind of sort of like batted around like it's oh, I have a cold. No, schizophrenia is a lifelong illness that will never go away unless you address it. And it's debilitating not only to the individual, but to the family. It's basically a doomsday diagnosis. Like, it's really bad diagnosis. And to, like, underscore it, or just like lazily, you just write it in there, it's irresponsible. And so what I have found, especially with the uptick of mental health, is that other treatment centers, they take previous diagnosis and they label it onto their forms, and they just move forward because, Jamie, they're just trying to check a box and they're just trying to move forward. And what I have found is I slow that process down, and we have found that the diagnoses have been way off. So what I do is I will take the least restrictive diagnosis that I possibly can. Obviously, if it's blatant, and a lot of times patients come in, they know more than the doctors know, and they know what they are. That's a different story. but a lot of times when I'm not sure, I'll sort of defer to a lower diagnosis, like some type of depression or anxiety, and then build it back up from there. Or if it's schizophrenia, I may not say schizophrenia, I'm not sure. I may do psychosis not otherwise specified, which basically means there's something else going on here. They're seeing things, hearing things not right. I'm not sure yet. I'm not sure if it's drug related. I'm not sure if it's chemical related. I'm not sure if it's environmental, but let me just go with this. And then we build it up. We build it up from there, and flexible enough, of course, to change the diagnosis if we need to. But this is such a critical component, because the other part of this is that it's really the backbone for the treatment plan and for the objectives that a person is going to be dealing with while they're in treatment. So that's another component to it. It also speaks to how a person learns, and that's such a critical component too. That, are you a visual person? Do you like to write things down? Do you, are you good with your hands? Are you artistic? And again, that all goes into the black cauldron, so that we can treat the patient in the best way, that we can. Again, another example is, when you get the right diagnosis, there are behaviors that you can be aware of. For example, somebody who is psychotic and paranoid, there's certain ways to approach them as opposed to somebody who's depressed or anxious. And so therefore, the diagnosis begins this teaching process and the supervision process of the staff, so that now we can treat the patient correctly. So can you imagine, Jamie, if none of that happens? We just fast forward, here it is, get the diagnosis wrong. Now everything starts to unravel. The staff doesn't know how to approach the patient. The patient is frustrated because nobody talked to them about how they learn and how to express your needs. The families are frustrated because they're on the wrong medicine. I mean, it is literally it's literally chaos. And so again, that's why diagnosing correctly is so important.
You talked about the black cauldron,
Yeah.
Sort of gathering information from different sources and, looking at everything holistically. How much of diagnosis is art versus science?
It's a great question. So early in my career, it was all intuition. It was just like gut feeling, right? Like, just now, there is an art to it. There's things that I look for, which I'll explain in a second, to diagnose appropriately. The scientific part of it is that I know the DSM really well, and I know the criteria. You've got, if you meet these 7 standards, you're a schizophrenic. If you meet these 9 standards, you've got OCD. So that's the science part of it. But the art part of it is based in, and I keep it very simple, and I'll simplify it for everybody this morning. I hone in on a biopsychosocial model. And so the art form is the physical well-being of an individual. What's happening with them? Are they diabetic? Are they obese? Are they have other issues, other medical issues, other illnesses? Do they exercise? All the things that attribute to the physical well-being of a person. So I start to formulate my theory. I start to formulate my diagnosis. The second part of that is the mental emotional piece of it. What makes a person, tick? Are they an angry person? Are they a paranoid person? Are they distrusting? Even though they're anxious, can they tolerate stress? And again, all of this is, I start to formulate this based on the information that I'm getting, plus the interview with the patient, interview with families, and of course with the staff. So the mental emotional part, are they med resistant? Meaning that, is this their 6th or 7th time in treatment? And they're just, they say things like, well, no medication works. Well, no medication works because you don't take medication because you refuse to. So, what kind of person is that? And then the third component is the social aspect. Do they isolate? Is there something else going on there? For example, a lot of folks that are psychotic, they may not be schizophrenic, but they're on their way. And what they do is they isolate, or they'll listen to music a lot. They'll just be away from the crowd, and they're well defended. They can still articulate, they can still fake well. And so you have to be very careful with that, because somebody with that kind of diagnosis, it could cause problems. It could be very confusing. So the social aspect, the social rehab aspect, very important. And then the last component, which I know you love, it saved your tush, which is the spiritual piece. Do they hate God? That's where you sort of find out, like, I'm the chosen one, I'm Jesus Christ, I was born in a test tube in the Middle East, and here we go, you didn't tap into it in the first 3, but now we see that, that a person is really off the chain. And so we take those 4 components and I put it into my black cauldron, and that's where the art is. Like, you just get a sense of where a person's head is at. Let me just give you one other piece too to that, is that I like to hone in on a concept known as self, world, others. What's your view of yourself? How do you see yourself? How do you view the world? How do you view other people? And I'll give you an example that we all can relate to. Every single person on this webinar can relate to. I know for me that September 11th, 2001, my world changed. That's the day, of course, that the airplanes hit the towers, and we were attacked by a foreigner for the second time. Pearl Harbor was the first time. And so the world became very small to me, and it changed things. And I became a little bit more cynical about the government and what really happened, and why did 3,000 people have to die, and didn't we know about it? And all of a sudden I started to view things differently, and it's really changed me since then. As far as the world conception goes, the the world is not as safe as I thought it was. I remember in 1979 when Ronald Reagan was becoming president of the United States and Iran had hostages. He came on TV and he was like, if you don't give up the hostages, we're gonna kill you. Like, we're coming after you. Like, I believed him. Like, it was like no one's touching the United States. And this was different. 9/11 was different, and it impacted everybody. So imagine if you're mentally ill or you have that sort of underneath current, it's events like that that can exacerbate the whole thing. Paranoid people get more paranoid. Depressed people get more depressed. And so what your view is, becomes very, very important.
Yeah. No, I really appreciate that combination of art and science that you employ, right? Like I said, if I was ever going to leave my job and do this, something I cared about a lot personally, mental wellness with anyone, they would need to be technical and be able to go into diagnoses and the DSM, and like that piece is important to me too. But as important with outcomes is that, are you intuitive enough to be creative, to have perception? And I feel like you are sort of the ultimate combination of those
so
things.
Let me just share a quick anecdote for you. So that, of course, Rick Seeley is our psychiatrist. So Rick and I know each other since 1993. And around 94, 95, I was in the middle of my master's degree, and I'm a tech and I'm working in a psych hospital. He's the he's the Uber medical director, he's a brilliant guy, top psychiatrist, worked for the Miami Dolphins, was all over the country. And I basically followed him around like a dog. I mean, I was like, I want to know everything. I probably irritated him by all the questions that I asked. Well, at one point, I was doing rounds with him, kind of like we do on Monday morning. I'm sorry, during the week in the mornings, and we would be sitting in these meetings, and I would take over. He would say, "Hey, Ben, you do it," and then he left, and I'm just lowly tech, and I'm meeting with other psychiatrists, and I'm diagnosing patients and doing all these things. And it was a crash course in how to diagnose properly, but it really set the stage for what I do now. I became faster and more concise, and it made me very uncomfortable back then, but it really led the way. It gave me that foundation that I can utilize, and I can be very quick with diagnoses and being more concise.
I appreciate the context. It's good. Sometimes I forget that this whole world of behavioral health existed before 3 years ago.
I know it has. It's evolved though.
So I'm gonna play timekeeper here because I want to be respectful of everybody's time and try to keep the next 4 to roughly 5 minutes.
Okay, I'll try.
The problem is we're about to talk family involvement, and I know you can talk about that for probably 8 days.
Yes.
That the family component of Sylvia Brafman, I would say, is probably the crown jewel of what we do. It is a non-negotiable for us that family is involved. We sort of view them as being in the virtual wing of the Sylvia Brafman Mental Health Center. And Ben, I know that's your baby, the family component. You run family night every Thursday night. By the way, we would welcome everybody on this Zoom to join family night one night. It's I would say probably the best view of the clinical substance of the program. In any case, Ben, talk to me about why that's such a critical component of good treatment.
So simplistically, if a family recovers, and when I say recovers, I'm not just talking about from the alcoholic or addict and that all that. I'm talking about recovers from how to deal with someone who is mentally ill, duly diagnosed. The percentage of the individual, the identified patient recovering, goes up about 75%. If the family is a united front, meaning that if they agree on how they're going to approach things as a family, the success rate goes through the roof. And I can't implore that enough. A lot of times questions come up about codependency and enabling and tough love and all those things. And I don't have the playbook on tough love. I tell families out of the gate, I almost don't care what you do. It's more about, are you doing it together? Is everyone on the same page? That's a critical component. And it's very hard to get families on the same page. You're dealing with egos, you're dealing with their own mental illnesses, you're dealing with time constraint and judgments and ego and all these things that play a role. You're also dealing with what their role is within their family system. Many families, just because you have a family and you're the mother and the father, doesn't mean anything to me. It doesn't mean that you spoke about it. It doesn't mean that there's clear boundaries. So I like to ask questions. I like to ask questions like, who's the disciplinarian in the family? Who do you trust the most in the family? Who's your go-to? Who's your role model? And so by asking those questions, we start to chisel down into who are the playmakers in the family, who's the weak link, and sort of how to approach it. I can't say enough about the family dynamics. A lot of times families and they don't do it on purpose, but they're literally the cause of the mental illness. They communicate a certain way day after day, week after week, year after year. decade after decade, and a person just is damaged. You know, their self-esteem is gone. They're depressed. They're anxious. A lot of times, you know this, Jamie, we have patients that get the heck away from their families, 3,000-4,000 miles away, and they still have the same issues because wherever you go, you have your family, right? And you have that dynamic. So it's twofold. The patient coming in is part of a family system. That's a fact. It doesn't matter if they're estranged or whatever. So you have to deal with that part. A lot of times we're talking about trauma. We're talking about sexual, psychological, emotional abuse. We're talking about, you know, alcoholism, drug addiction, all of that. The other part of it is the families coming in that they need help. They don't know what to do. Sometimes that means convincing the families that they need help. Sometimes it means directing them. They want help, they're motivated, but now we have to direct it a certain way. So I spend time supervising the staff and working with families on a thing called family constitution. Family constitution is, again, this concept of a united front where families come together and they identify, okay, I don't like when you do this, I don't like when you do that, and what works, what's a good compromise. And this family constitution is boundaries. You know, what's fair? You know, what can we talk about now? What should we talk about later? And if families start to respect each other this way, trust starts to build. Once you have trust, everything is on the table. You don't have that trust, it's over. You know, and so you can come to the table, and that's a lot of times what I do in family night is that I get people to the negotiating table where they start to hone in on what's really going on with them, what's really motivating them, what is this anger about, you know, and recognizing, having families recognizing that words hurt. And you know, and when you say certain things, it impacts your child, and when your child says certain things, it impacts them. And again, I'm being a little stereotypical because we treat spouses and boyfriends and girlfriends and grandmas and, you know, and all that stuff, but nonetheless the point is the same, and it boils down to communication and consistency and structure and, of course, trust.
Yeah. Two quick reactions. One is we'll be on a Zoom with a family oftentimes, and like you'll talk to the patient for a minute, but quickly you'll move over to the family member and you'll ask them how this is impacting them, and they're like always kind of taken aback.
Right.
And so it's interesting seeing like the emphasis that you put on that relative to, I guess, what many folks are used to. And then the other thing is, my sober date, I celebrated 10 years on Christmas Day. So Christmas Day every year is always a special day. It's also kind of nice that it's like quiet, right? There's, you know, you're not going to go to work on Christmas. So it's a day of reflection. So I always take out this bag. I have this bag of all stuff from the past. Good, my notebooks from different treatment centers I was in, letters from the courts, right? Just all the stuff that brings me down memory lane, and really it's not sad anymore. It's more about gratitude that, thank God, this is where my life is. And I saw a letter this year. I don't know, I missed it the last couple of years, I guess, from my stepdad, Michael, to me, that I guess was an assignment that you gave him when I was in Destination Hope.
Yeah, letter writing is big for me. Yeah.
Yeah. So the family needs to do work while the patient is doing work.
And let me say this to you too: what you're picking up on, you know, when we talk to families or you see me in action, is the following. Many times, and I would say at least 50% of the time, if not more, the identified patient that's in treatment is not the problem in their family system, and that is one of the challenges of the staff, is to change the view of the families that this is not about this individual being the problem. In fact, they might be the healthiest one in the family system. They actually might hold the answers to the rest of the family. Families have all kinds of agendas and manipulation as to why an individual ends up in treatment. Honestly, multiple family members probably need to go to treatment But they're not the problem. And I tell them that all the time. I tell the patients that all the time, which is why I hone in on the family the way that I do, because more times than not, they're the problem.
So I just want to make a quick announcement because we're beyond the midway point that I think there may have been an issue with the Q&A feature. It should be working now. There's only a small number of questions that have been submitted. We're going to get to them in probably about 15 minutes. If you guys have any questions as we're having this conversation, you don't need to wait. Feel free to just throw it in the chat. Ben, I want to talk about your number 4. Is it 4 or 5? Yeah, it's number 4 on this list. Having fun, a critical component of good treatment. I actually wrote this bullet here about getting the belly laugh back.
Yeah.
Because I remember experiencing that in treatment. It was my 7th treatment center, and I totally forgot what that was like. And that was like a really critical moment for me because I viewed getting better, mental wellness, recovery as like gloom and doom, like sitting in my discomfort without the only coping mechanism that I had, which was drugs and alcohol at the time. And it showed me that no, we do this so that we can be a part of life. And so, yeah, talk a little bit about why that's so important.
Yeah, so this part is so critical, the social rehab component of treatment and having fun. Generally speaking, the public feels that rehab is gloom and doom. Like you said, it's sad, it's dark, it's depressing, it's all those things. And that's the stereotypical stuff. And frankly, couldn't be further from the truth. One of our pillars is the comeback, and my favorite, that's my favorite one, is the comeback. And the comeback is exciting. I mean, if you ever watched sports, I mean, who doesn't love a comeback? I mean, the underdog, that I thrive on that. I mean, that's the story of my life too. And I want that for each patient. I actually get excited when a patient comes into treatment because they're that much closer to getting better. And so in terms of having fun, sometimes fun takes the form of the following. I want patients, and everyone should want patients to do stuff while they're in treatment outside of the work, outside of the group therapy, whether that's eating together, whether that's watching a movie, whether that's going on some sort of outing, if that's your structure, whether it's even an individual private practice in therapy is giving somebody homework, to go do something, maybe exercise a little bit more, reach out to a friend, letter writing, which is a big deal for me. Just doing hobbies, having fun, doing things that are different than than the normal day-to-day mundane stuff that goes on. Part of the reason a person is in treatment is that they're bored. They're bored with their life. They've come to this sort of this dead end, this nothing's working. The road is very narrow. They don't feel like they have enough left in the tank to pull themselves out. They don't feel like they can trust anybody, not really. They don't feel like medication is working. Their bottom line is people are not listening. And when you start to do normal stuff that maybe the general population does, and you start to get out of yourself a little bit and start to have fun, you don't take yourself as seriously. And once you do that, you're able to see things for what they truly are. Like it's, just because you're depressed and anxious and even, if you have a thought disorder, it is not the end of the world, not even close. And there's so many creative things and fun things that you can do. So that's a component that is, that is so critical. The other piece of it is you're doing something maybe that you've never done before, and that speaks to ego. And a lot of times in treatment, people come in with these egos, and it's not so much like narcissistic or whatever. It's basically you've convinced yourself that you are your illness. You are a depressed person. You are an anxious person. You are a psychotic person. And you've lied to, you've believed the lie. You believe the fantasy. And that's the ego, right? The ego is, this is who I am. This is who I'm going to be. And again, it's not true. And so part of treatment is introducing these other elements where art therapy and yoga and letter writing and going to the movies and having a barbecue and just getting out, getting outside if you're talking to somebody. These are such important components to good treatment, and being successful and having that comeback. There is nothing better, and I've been doing this for 26 years. There is nothing better than seeing a patient come in at day one and then fast forward to day 30, 60, 90 and seeing what they look like. I compare it a lot to Tom Hanks in Castaway. He was stuck on this island for 4 years. And if you recall, he's thin, his big beard, and, just suicidal. I mean, he was a wreck, pulled his own tooth out, it's all craziness. And then, you see him, fast forward, clean shaven, professional, all these things. That's the comeback, right? It was a disaster because a lot of us do live on our own island, and it's a disaster. And so, he came out of it. Everybody can come out of it. There's no question about it. And that comeback is critical, and having fun is such a key component.
People ask me, like, what was the difference between, the 7 times that I tried to get better, by going to treatment, and the last one. I mean, there was it was this perfect storm of, I would call it a spiritual, an emotional, and an intellectual surrender, all kind of wrapped up in one. But a big shift was, I viewed this as, again, life minus the only coping mechanism I have, from that to life plus recovery. So it was additive. Because I saw people around me doing the things that I always wanted to do. Traveling, going on dates with cute girls, and getting back into school and getting good jobs. I'm so blessed that I've been able to travel the world, go to school. Like, my life is no different than someone else my age who happens to drink. So
Right.
that why are we doing this otherwise? So that has to start in treatment, and I appreciate that big time. So I want to keep the next 2 to actually 5 minutes if we can. I'm going to take responsibility for not cutting you off.
All right.
Number 5 of 6, patient retention. Yeah. Talk to me about that.
So, keeping patients, it's getting them through that first wave. There's some key elements to that a treatment center can do that, will make them, stand out. First off, the relationship between the patient and the therapist is critical. That's number one. Number 2 is the family involvement. You got to have family involvement in order to keep the patient in treatment, keep them interested. And the third component is what we just talked about, and that is the social aspect. I could literally go right now into the community, and I could tell you, based on behavior, if they're on break, who I think is struggling more than somebody else based on where they are physically within the community. And when you're isolating, you're not part of. When you're ruminating, you're not part of. And so that becomes difficult when a patient is starting to think, I don't want to be here anymore. So those 3 components, though, are critical. That patient has their go-to, which is their therapist, right? Should be their therapist. That the family is involved, and they'll continue to be involved, and that they're socializing, appropriately socializing with with the community in general. Those are really the highlights of patient retention.
Yeah. And I'll just say, like, I think when we got started, I asked you, because I was new to behavioral health, what is the ideal length of stay? And you would say, typically 90 days, right? And then, the more we've worked together and I've dug into it, it's really a triangulation. The length of stay at a place like ours, like, PHP with housing or maybe residential first, followed by IOP, is a triangulation of three things, which is one, the most important is obviously what's clinically indicated. And that's
Right.
obviously going to be different for different people. Two, what are the life circumstances of that person? Meaning sometimes someone simply needs to get back to work. And whatever those circumstances are, how long can they actually press pause on their life for?
Yeah.
And then three, unfortunately, sometimes the financial aspect, we really stick our necks out to make sure people get the care that they need. But at a certain point, we try to be resourceful until there's just, nothing we can do. So we prioritize what's clinically indicated. But why do you say 90 days? And by the way, I think what you mean by that is that can be a blend of multiple levels of care. There are often times where people come to us, from all over the country for 30 days of PHP, and then they do IOP. Sometimes they can do that virtually, but why do you say 90 days?
Because 2 weeks, 30 days, you can fool anybody. 60 days, it gets a little bit more difficult. By 90 days, we're going to know who you are and what makes you tick, the good, the bad, the ugly. We're also going to get to know the family members. I will guarantee you there's going to be some type of crisis that goes on in those 90 days. There's going to be breakthroughs. There's going to be temptations. What happens in treatment is that the life that you had out there becomes the life in here. It's a microcosm. And so the stressors that you deal with, let's say you're going through a divorce. So the stressors of that are going to impact you while you're in treatment. That's guaranteed. And the way that you deal with that is going to come up. And I'm pretty sure the way that you deal with it or had been dealing with it is not healthy. So that'll be addressed. Legal issues that come up, same exact thing. 90 days is a good time period. Also medication. 90 days a great length of time to see if medication's going to work. And I'm talking about any medication. It could be Zoloft, for your depressed or anxious person, all the way up to lithium, where you have to check your blood levels, for bipolar disorder, to even injectables, for schizophrenia. The 90-day mark it sort of like covers the bases, for behavior and what we're going to see, patterns of behavior.
Sure. All right. Last but not least, continuity of care. One of your components of good treatment. Can you talk a little bit about what that is, why it's important?
So I'm as passionate about continuity of care as I am about informed consent. It's like the two pieces of bread here. And if you leave, let's say you kill it, right, in treatment, you do great. You go to every group, you do all your assignments, all that stuff, and you're going home to the environment where you came from with no plan, just the attitude that I got this. You ain't got it. You ain't got anything. And without a plan, everyone is going to fail. You cannot make this up as you go along. It's too critical. There's too many complexities, and there's variables that you have to consider. You have to consider family component. You have to consider your job, as you alluded to, your financial situation, your relationship status, your hobbies, all of that stuff. And you want to be able to work on what life is going to look like after treatment, whatever that means, while you're in treatment. And I'm a huge component of, if you can leave treatment while you're in treatment and sort of test the waters, like we do at the PHP with housing. We might have like a day pass with the family, or they do a sleepover. 100% for that, because if I can build up wins and we give them the structure, a script basically of do's and don'ts, this is what you do, this is what you don't do, we can move forward on that. And that's such a critical component. The other thing is convincing the patient to try something different that they haven't done before. A lot of patients are like, a lot of men are like, I just need to go back to work. I need to go back and take care of my family. And the hard reality is that, well, what are you offering your family right now? You got nothing. Like you're a blob. I mean, you're not going to be able to do anything for them. And so that's why you introduce it immediately, because it's going to take time. It's not really fun to hear that you don't offer your family anything when in your head you're the guy. So that there's that component of it. Setting yourself up with appointments, psychiatric components, physical therapy, going to the gym, all of these things play a critical role. And let me say this, you can't treat everything in treatment. You just can't get to every little thing. And so within treatment, you should be deferring some of these other things that are going to come up outside of the 30, 60, 90 days or what have you. And as a clinician, and this speaks to good therapy, a good clinician who's doing the right thing is documenting the deferment, right? They're documenting, okay, we're not going to address this, but they should address, for example, while we address trauma now, trauma used to be a thing that, well, we'll defer it. We'll do, individual therapy later. So that should be documented. Person is gonna, they're gonna work on their obesity, post-treatment. So it should be documented. And then when they leave, there should be an appointment with an endocrinologist, or their primary doctor. There should be, just assignments that are set up for them. A lot of our young guys, that have drug issues, they go to halfway houses. We know that a lot of halfway houses stink. And so it's not like on the 30th, 60th, or 90th day, I don't want to scramble around and send them just to some random place. We want to pick a place that we know is really good. Let the families go see it. Let the patient go see it.
Yeah. And by the way, I remember this too, when I was in my last treatment center, right? My point is, I appreciate the individualized sort of approach that what works for one person might not work for somebody else. They were just the status quo when I went to Florida, right? But I had a job in New Jersey, kind of. I was loosely working. But at that point, the best move for me, because I had a sponsor, because I started getting plugged in, was go to sober living in New Jersey and hit AA hard. And that's exactly what I needed, not to stay in Florida.
Right.
So we're not married to, you have to go to this. No, sometimes the move is to go back home. And sometimes 100%. It's not, and we really just need to be intentional about what that recommendation is.
And let me say this to you, because this is important. Here's the difference between good treatment and not so good treatment. So good treatment is doing exactly what you just said. It's individualizing it and doing what's necessary for the patient and their family. Not so good treatment is being tone deaf to all of that and saying, well, we just revert to ABC halfway house. And theoretically, depressed people need to go to an individual psychologist, and that's it. Like, what? It's like you're not treating the person, you're treating the idea of the person.
Yeah.
And that's a critical component to shift gears into being a good or great treatment center.
Yeah, I think that's a great note to end on. That kind of puts an explanation point on the entire spirit of the presentation today. Some of the other topics that are definitely a part of good treatment that we didn't cover today, but that we will cover in future sessions. Qualifying prospective staff members. I know that's very tough today to find good staffing. Ongoing training and supervision. I know, Ben, you are all about that. Everyone has supervision at least once a week. Evidence-based practices, dignity, respect, and environmental considerations, comprehensive treatment, right? Looking at the whole person. personalized treatment plans, program performance measures or metrics, and accreditation. So these are topics that we're going to hit in future roundtables. We hope to do this definitely once a month, possibly twice a month, and offer CEU credits
Fantastic.
for all of it. So I want to open it up now. We've got about 20 minutes. We don't need to take that whole time. Of course, it's whatever the crowd is asking for. So I see that some have submitted questions. And I'll take a look and just sort of read them out loud. And of course, anyone else is welcome to submit questions too. So first question is from Ashley. Okay, it's I see here. Do you ask family members to oh, it went away. Michael, do you see where that went, that question from Ashley? I don't know what happened. It sort of addressed that I was asking the question. And then it, you know what?
I see it now, Jamie.
You see it now? Where is it here?
Just go to answered.
I see. Okay. Do you ask family members to enter their own therapy to help the client in your care?
Yes. Some of them come in with their own therapist, which is not good. They're usually getting, somewhat poor advice, but yes, they should enter therapy and if this is possible, if the treatment center can do the therapy, then that's what I would advise, that they would come in on a weekly basis or whatever it is, Zoom or in person, to do the therapy. And just to add to it, Jamie, that I love this question because to me it speaks to success. To me, success is a family getting it, not so much the patient getting it, because the family gets it. Like I said in the beginning, the percentages of the patient getting it go through the roof.
So when they're with us, right? I know I've heard you recommend that, but generally because we're so high touch, we are essentially the therapy for
Yeah.
the family.
Yeah.
Are there times where you say, hey, you need maybe a heavier dose of therapy, you should see somebody in addition to?
Yes, it happens a lot. What happens oftentimes is that the parents are not on the same page. Typically, moms are emotional and they've been the one that have been carrying the burden. And a lot of times I'll push them to get their own therapy, because not only are they probably codependent, their marriage is not healthy. And so it's good for them to have their own sounding board and get the help that they need.
Great. All right, from Barbara. In my work, I recognize how important family work can be. Can you recommend any books, theories, etc., to focus or read about to get more in-depth therapeutic style as a family therapist? I'm very familiar with Salvador Minuchin. Can you recommend others?
Yes. So there are several books out there for people that have a substance abuse slant. I recommend Craig Natkin, Understanding Addiction. I can and anything that I reference now, Jamie, I can send to people. That's number one. There is a fictional book called The Quiet Game, by Greg. I forget his last name as an author, but I will get it to them. That has to do with secrets within a family. Now it's fictional and there's a lot of drama and everything, but that's a fantastic book. Anything, if you want to read some of the foundational concepts of family therapy, Gregory Bateson, he one of my mentors that I never met, but I read about 3 of his books. Gregory Bateson was an engineer. He actually figured out the how we do family therapy is what he came up with, which was it's a system. And he talked about homeostasis, and he talked about balance, and he used the metaphor of an air conditioner. And he was able, because he was an engineer, he was able to break it down mechanically. And just a brilliant guy. His daughter has moved on with his work. Gregory Bates is no longer alive, And then you mentioned Salvador Minuchin. Minuchin was a proponent of systems and structured therapy. Jamie, you'll like this. He was a Israeli guy who he did a lot of his studies on kibbutzes in Israel, and he's the one who came up with subsystems. You know, you have the system of you have mom and dad, right? I'm sorry, you have husband and wife, then you have mother and father. Those are two different subsets, even though they're the same person. And then the third is the children. Obviously, that's a stereotypical family. You have other subsystems, but that anything on Minuchin, fantastic. And of course, those other books, and I can get other references for people.
Great. Yeah, I think Maribel just said she would like a list of our recommended reading, whatever you recommend to read. So we'll definitely send that around as a follow-up.
I have recommendations that seemingly you'd think I'm crazy, and say, why is he recommending this? But I could even write like a little thing for people, like why I'm recommending it. It's required reading. Like there's certain things, certain books out there you should read. For example, everyone should read One Flew Over the Cuckoo's Nest by Ken Kersey. Why? Because the movie's fantastic. Jack Nicholson chews up the scenery and stuff, but the book is written through the eyes of the Indian in the movie, and he's allegedly schizophrenic. He hears things, he sees things, this whole thing, it's through his eyes. If you ever want to get like a good grasp of true mental illness, that's the book to read, and you'll know right away what's happening. It's really fantastic.
I'm gonna actually piggyback on that question, Ben. Any recommended documentaries or movies?
Always 100%. So in terms of mental illness, One Flew Over the Cuckoo's Nest is a good one. Beautiful Mind is a really good one. In terms of like drug addiction and stuff, there's an older movie called Drunks with Richard Lewis, Faye Dunaway. It's like this all-star cast. It was like a 90-minute movie, and it's basically takes the place in a 24-hour period during an AA meeting. Really, really well done. I actually made the therapist watch it. They all loved it too. So, it's really, really good stuff. There's Fatal Attraction with Michael Douglas and Glenn Close. You want to see what a borderline looks like? It's an extreme example, but borderlines do boil bunnies. So, there is that. So there's just a lot. And yes, I will 100%. I will 100% make a list for everyone.
Fantastic. So I think we will close on that note. This has been amazing. I could listen to you talk all day, Ben.
Thank you.
Luckily, I get to. And once again, if you didn't fill out the Google form to get your CEU credit certification, please make sure to do that. Michael will send, we'll send one follow-up email that will have the deck, that will have the recommended reading and movie list, and that will have any information on getting your CEU credit. So thank you, Ben, once again. Thank you, everybody, for joining. This has been awesome, and really excited for the next one. So hope to see you then. Thank you.